Good morning, everyone. Thanks for joining us. We're just going to take a few minutes to let everyone log on, and then we'll get started right at 8:30. Just a couple more minutes to let people continue to sign on, and then we'll get started. All right, good morning, everyone. I hope everyone's having a great week so far. My name is Taylor Gonzalez. I am one of the Business Development Associates here at HRG. I want to thank you guys for joining us this morning for the second webinar in our Outbreak Outreach webinar series. During this unprecedented time, HRG is committed to sharing the industry information that you are accustomed to getting from canceled industry events like conferences, HFMAs, that kind of thing. A couple things just before we get started. Please feel free to ask questions in the question box right to the right of your panel there. To make sure that we honor the time that we have allotted for you guys, we want to make sure that we stay within that 30 minutes. What we're going to do is send out the answers to those questions in an email later today with the presentation slides as well as the recording. Feel free to share that with your team, anyone that you think would benefit from this information. This morning we have HRG's resident telehealth expert, our Executive Director of Training and Quality, Megan Smith, to give you all that you need to know about billing for telehealth in response to the COVID-19 increase in these services. So with that, I'm going to give it to Megan and have her get started.
Okay, great. Thanks, Taylor. Good morning, everyone. March has been an extremely busy month in terms of changes, regulatory changes. CMS has been very busy, kind of behind the scenes, making changes so that we can, so that providers can support some of these patients. So we have a lot of content in these slides. I want to make sure that we can get through most of it. So I'm just going to summarize what we have here on these slides, each of these, and as Taylor mentioned, we'll go ahead and send out the presentation so that you can really dig into some of that detail. Okay, we'll go ahead and get started here. Okay, so when we talk about telehealth or telemedicine, there's some key industry terms, and most of you are probably very familiar with these. What we're really going to focus on today is the telemedicine or telehealth piece of it, which is the virtual connection, the audio and the video connection that the provider has with the patient. There are other things such as the virtual check-ins, which is the shorter 5 to 10 minute check-ins that a patient can do. These are the patient begins this conversation with the provider. There's also the store and forward, which is the patient goes into a clinical office, does an audio recording along with a visual usually, and then that gets saved and sent over to the provider to review and provide information back to the patient at a later date. Another key industry term that we're going to talk about is originating site as well as distant site. So some of the biggest things that happened. So when our president declared a public health emergency in March, this allowed for several waivers and relaxed regulations under Section 1153 of the Social Security Act. So what that means is the biggest piece is the originating site geographic restrictions have been waived. So starting with dates of service March 6th and beyond, CMS is allowing patients to contact their providers or the provider to contact them from their homes. Now, last year, there was an expansion to telehealth, which allowed patients to use their home as an originating site for things like stroke, and then I believe opioid abuse counseling, and along with mental health counseling as it relates to opioid use. But this is for everything. So the expansion includes all diagnosis codes, so the patient can use telehealth from their home, whether they're having just the sniffles, they think it's COVID-19 related, or if it's something completely different. Those are all going to be covered as long as the E&M that is being provided is something that's covered. So one thing I do want to note here though, and this could be a big change, is facilities cannot bill for an originating site fee if the patient is calling from home. So that is going to be a loss of revenue for the folks that can only bill as an originating site. So as of the end of March.
Pause just for a second. I'm
Sure.
getting some messages that people aren't hearing us. Can you guys confirm that you're hearing us? Just go ahead and answer in the question box for us. Okay. All right, you can go ahead and continue. It looks like most people are hearing us. Sorry about that.
Okay. Oh, not a problem. Not a problem. Okay. So continuing on here, at the end of March, CMS expanded the services that they are going to cover under telehealth. So they have added 85 additional services. Those services or those codes date back to 3/1. So for service dates from March 1st and beyond, they are now published on the CMS website. So that handy little link that you use to get the services, that list in Excel, those have been added and they're indicated as a temporary code due to the PHE, the public health emergency. So these additional services include emergency department E&Ms. One thing to note is these are not subject to EMTALA during the PHE. Home visits are included, hospital discharges, initial observation care, nursing facilities, critical care for adults and peds, and also a broad range of therapies for PT, OT, and speech. So one thing that you want to note, and this is important, is these expanded services are the ones that are indicated as temporary during the PHE. Those you have to bill a little bit differently. So when you put them on your 1500, your place of service should not be 02 for telehealth. They have indicated, now this may change because this is very new, it just came out this week. They have indicated CMS would like to have the place of service equal to what it would have been if it wasn't a public health emergency. So if it's for the emergency room and you're doing an emergency E&M over the phone, then you would have the emergency room place of service on there, not the telehealth. The way that you can tell CMS that it is actually services provided by telehealth is you want to put that modifier 95 on there. And which is a little different because typically that modifier 95 is used for the store and forward services for telehealth, but this is what they're advising us to do in their billing guides. Okay, there we go. So another item is the patient prior relationship requirement has been waived. So telehealth, typically you have to be an established patient with that provider. They are waiving that because they are highly encouraging patients to stay home and to utilize medical care from their homes and not go out into the public and potentially spread what they have or put other patients, put themselves under risk. So both new and established patients can utilize the telehealth. And one thing, this last bullet here, is that HHS will not be conducting audits on claims. So they're not going to go back and see if the patient truly was a new patient or an established patient when you're billing with those codes during this public health emergency. So providers can also use additional technology. So previously it was specific technology they could use. It had to be housed in the office or the originating site, and then the provider had to use similar technology when they're providing care from the distant site. They have opened it up quite a bit. So you can use Apple FaceTime, you can use Skype, Microsoft Teams, WebEx, GoToMeetings. The important piece here is that it has to be a non-public facing application. So you can't use things like Facebook Live, Twitch, TikTok, and other public facing applications. And then also something that just came out at the end of March is that providers can now evaluate their beneficiaries and their patients on audio only. And so the requirement used to be you had to have the video and the audio. Now they're allowing folks to just use their telephone to be able to talk to a provider, and that is a billable distant site service. So CMS also said that they are allowing providers and insurance companies to reduce or waive the patient cost share. So if a provider chooses to discount or an insurance chooses to discount the out-of-pocket, the co-pays, the any kind of co-insurance, they can do that, and it's not going to be an issue during this time of a public health emergency. And I do have at the end of this, because this is a pretty big deal, and we want to make sure always that we're following CMS guidance, especially when it comes to beneficiary cost share. So we do have an attachment, or excuse me, a resource at the end of this slide or this presentation where you can take a look at that link and it'll give you the CMS guidance on that. So on March 10th, CMS sent a memo to the managed care plans giving them guidance, not only for the things that we just talked about in the expansion, but also they said that, hey, if you want to add more codes to that, then that's fine. We're going to allow you, it is permissive, we're going to allow you to add additional codes to that in order to support your beneficiaries. They said you can choose, so CMS will allow managed care plans to waive prior authorization requirements. That's for things such as Part D drugs and retail pharmacy. Also, they're allowing them to waive authorization requirements for coronavirus testing and also visits. So if there's any additional authorization requirements prior to this, they're allowing them to waive it. And then this last bullet here is important, that patients that are seeking care at a non-contracted facility, they're going to get the same level of coverage as a contracted provider during this time. So additional items on that memo from CMS is previously the managed care plans were required to give a 30-day notification when they made changes to the beneficiary's plan. As long as the beneficiary will benefit from the change, CMS is waiving that requirement of the 30-day notification. So things like they're waiving the requirement for prior authorization. That's something the managed care plans can put into effect immediately. It is a benefit for their enrollees, and so they do not have to do the 30-day wait. They're also relaxing the refill too soon edit. So if a patient has a requirement to wait a 60 or a 90 day before they get their refills, they want patients to, in the event of a quarantine, they want patients to have their medications that they need. So they are relaxing that edit. I would take a look at that if you are a pharmacy provider or have a retail pharmacy, because there are some codes that they're not allowing that. So I would take a look at that. And then they are relaxing the plan imposed policies, discouraging certain methods of delivery. And what that means is previously, if your retail pharmacy required a person had to come in person to pick it up, they're allowing you to mail the drugs. Now there's also a list for that is allowed, but they're allowing the providers to mail the drugs to the patient so that they don't have to leave their house. So what is Medicaid doing in all of this? Lots of changes. Medicaid is right there doing what they can to support these changes for CMS. They fall under a different requirement, if you will. They have to apply for waivers. As of March 31st, there were 40 states that had applied and were approved for waivers under this section of the Social Security Act. And what this means is it provides, it's a high level, it gives them relief in prior authorization requirements, provider enrollment requirements, it suspends certain nursing home pre-admission reviews. Each state is doing something a little bit different. And so I can't say enough good things about this website right here. It will allow you to drill down into the specific state. And so I've put this on here as a resource for you guys to use, because it would be a lot of slides to include what all 50 states are doing, but they do have that information out there. This website is updated on a frequent basis, almost an hourly basis. And so I encourage you to check your state under this website to see what they're doing as far as in terms of their Medicaid fee-for-service plan. So what are the commercial insurances doing? So most of the commercial insurances are sending out information almost as frequent as CMS's. There's lots of things out there on the web. They look to be supporting, for the most part, supporting the changes in the expansion that CMS is imposing, but they do have some time frames attached to these. So what I've done here is we're taking a look at the top 5 in terms of, the expansion that CMS is doing. So have they waived the originating site? I would say across the board, all commercial plans are waiving the originating site, and that does include under Aetna, who has several self-funded plans. They are also waiving that originating site. Is there a cost share reduction? Yes, across the board, especially when it comes to the telehealth and the COVID-19 support. They are waiving, they are doing a cost share reduction. I will say though, for Aetna, they did have and it was very fine print on their website. They said that the self-funded plans can choose to opt out of the cost share reduction. So you may want to check into that if you have some patients that are falling under those union plans, the self-funded plans, because they may still require the patient to pay their copay or their portion. Can they do an early medication refill? So I'd say 4 out of 5, they said yes. It was noted in their documentation. United Healthcare has a lot of information out there. They're sending things out every couple of days. They may have changed it, but as far as my research from last Monday, when I took another look, they did not have any additional information on there regarding early medication refills. But I can't imagine, especially with the number of plans, the Medicaid and Medicare plans and commercial that United Healthcare has, I'm sure they will follow suit. Waiving prior authorization requirements. So Aetna didn't say anything specific to that, although they do have a lot of plans, self-funded plans, kind of rolling up under them as an umbrella. So maybe more specific state plans would have more information, but just in general on their website, and each one of these payers has a COVID-19 website that you can go to look for support. Aetna didn't say anything specific, so you may want to double check on that one. Blue Cross Blue Shield, along with Cigna and Regents, they're saying for COVID-19 tests only. They will be waiving prior authorization requirements. United Healthcare said COVID-19 testing along with site of service surgical codes. So this is pretty big. So for those of you that have worked with United Healthcare to get authorizations, especially for site of service surgical codes, it's a process. And so this is pretty good. Although I would say there's probably not a lot of the elective surgeries happening right now, so their timing is interesting, but they are waiving prior authorization requirements. They're only doing it through April 30th, and there are a couple of other payers that have put some time frames on these. But I would imagine as we progress through the coming weeks, and depending on what the state is doing of the COVID-19, they may expand this as well. So it says April 30th for now, but I would watch because I would imagine they're going to expand it. So something else that just came out very recently is the CMS Telehealth Toolkit. So they're calling it the Long-Term Care Nursing Homes Toolkit, but really it is beneficial for anybody that is providing telehealth or wants to provide telehealth services. It's a pretty cool kit. It's very long, but it has details regarding the expanded telehealth services. So what we've already gone over in the earlier slides, it's got a lot of details there. It has links for statute guidance. It has an implementation guide. It has a vendor selection guide and checklist. It also has several articles, and it's very updated. It has a lot of newer information in there, a lot of things from March. And I put the resource down here at the bottom of the screen here so that you guys can see that. It is a CMS document, and it is pretty cool. So I would definitely check that out. So let's talk about the things that have stayed the same. So the distant site list does remain the same in terms of the providers that can bill for distant site. They have not expanded that at this time. But what they have done is they've waived the requirements for the CRNA supervision. They also said that they are relaxing some credentialing requirements. Now, I didn't dig into that too much, but there is a lot of information out there about the credentialing requirements, especially when it comes to Medicaid plans, and they are allowing for some waivers or some relaxing requirements on that. So I'd take a look at that. That website that I put up a couple slides ago on the Medicaid slide, that will let you know also of the regulatory requirements and the changes that they're making. So it's a good place to go. Teaching physicians can now provide supervision using audio video communication, so they don't need to be there in person. That requirement has been relaxed. And then also this last bullet here, it's going to make it tough for our coders, and then also perhaps when we're doing, if we have to appeal any of these claims, because we're looking at a wider use of verbal orders rather than written orders. This came out very recently. It was literally in a MedLearn Matters on the 31st of March, and it was just a simple little sentence in there. And I did a lot of digging over the last couple of days, and I couldn't find any more information because I want to know what CMS is permitting a verbal order on and what is still required to be a written order. So I'm still going to be looking for more information, and then hopefully we can send something out as a follow-up once I do find additional information, because you definitely want to follow that, especially when CMS is allowing us to do some verbal orders. Like, what does that mean? We don't want to do verbal orders on something that's not allowed. So just to kind of get down to the basics here, billing for a distant site, it has not changed. So if you're a method 1, you're still going to bill it on a 1500. Your place of service is going to be a 02, and you do not include the GT modifier. And this is for Medicare specifically. Your commercial plans and your Medicaid plans, they may want something a little different. Check that website for the state requirements that I referred to. It should give you that information on what they need in order to bill for telehealth services distant site. For your method 2 critical access, same CPT code. This time you're going to bill it on a UB04 with a type of bill of 851. Your revenue codes are going to be your 96X, your 97, or your 98. Your GT modifier is appended to your E&M. That's what's going to get your claims paid. That's the way that Medicare wants to see it. So this is just kind of a bonus slide here, and it refers to the drive-through testing. So there's a lot of drive-throughs that are popping up here and there. CVS is opening up a ton of them, and there's also more on the on the more private sector, where they're opening up a drive-through testing where a patient comes in, doesn't get an assessment. They may have done an assessment over the phone previously, and then the provider told them to come in to do the testing. But this is how you can bill for strictly the specimen collection. So there's also a link that we will provide on the resource page at the end of this presentation. But basically, your specimen collection is going to be billed on a 1500 with a place of service of 15, indicating mobile unit. That is unless your drive-through is in close proximity or basically an extension from your department. So if it's an extension just outside the emergency room, you would use the emergency room place of service. The AMA is providing a code and suggesting the 99001 can be reported for the swab collection. So these next two bullets at the bottom here are really important. You want to make sure that you're appending your CR modifier to indicate that this is catastrophe related. So the CR modifier only comes into play if the president declares a public health emergency. So when they've declared a public health emergency, then you can only for certain services, the services that CMS gives you guidance to use this CR modifier. They announce, and so when things like this happen, when we are in a crisis, when we do have a public health emergency, you want to wait to see for CMS to give you the green light. So in the MedLearn Matters dated March 20th, they said, okay, you need to start using the CR modifier for specific services. I will note the telehealth expanded services we talked about in the beginning of the presentation. They said specifically do not use the CR modifier. So this CR modifier, I would use this for the 99001 because it's a unique swab collection for a drive-through service just based on COVID-19 support. So this last little bullet here, CMS is now ready to accept those claims. So their system was not updated to accept the CR modifier until 4/1. So as of yesterday, you can start sending those claims to them and you're not going to get a rejection. This is for dates of service prior to, so if you're billing for this code and for March dates of service, it will still accept it. That 4/1 date just indicates when their system will actually be able to accept that CR modifier. So here's that resource page that I was talking about. So there's lots of links on here, lots of really good guidance that you can use along with a lot of the MedLearn Matters that you can read, that you can look at to kind of give you confirmation. Tuck those away, keep them just in case you run into any issues with your claims so that you can say, hey, this is the guidance that I was following. And that is actually the conclusion of my presentation. So it looks like we got done a little bit early. Taylor, back to you.
Awesome. Thanks so much, Megan. That's so much good information. Would you mind just going to the next slide for me?
Sure can.
Awesome. Well, you guys, thanks so much for joining us this morning. We are really excited to be able to provide you with this information and just be a resource for you guys through this time. Next week, we will be back again at the same time, Thursday morning at 8:30, and we will be going over denials, conquering denials, how to win the war with Cassie Wise, our Executive Director of our Complete Business Office Services. Feel free to go ahead and register. Also, as I had mentioned before, we will be sending out an email later today that will include the answers to any of the questions that you guys asked, as well as the slides and the recording of this webinar for you to share. If there's anything that comes up, that email will come from me. Feel free to reach back out and I will be sure to get you the right resources that you're looking for. And then with that, we will see you next week. You guys have a great rest of your day.